Her name was Patricia. 71 years old, retired school principal. She could recall every student she'd taught for 30 years. Birthdays, names, faces, all of it. Her husband called her a walking yearbook. 14 months after her doctor added just 2 new prescriptions to her routine, her daughter found her sitting in the driveway at 11 p.m. Patricia didn't know which house was hers. Her neurologist diagnosed early-onset Alzheimer's. The family started researching memory care facilities. They were devastated. But here is what nobody, not one doctor, not one pharmacist, ever told them. Patricia did not have Alzheimer's. She had a medicine cabinet. When we conducted a full medication review and made targeted changes under her physician's supervision, Patricia was back to herself within 3 months. She cried at her own dining room table the first night she remembered her daughter's middle name. I'm Dr. Deborah William, and what I'm going to show you today isn't a scare tactic. It is clinical reality that millions of families are living right now without anyone ever warning them. 9 medications, ranked from commonly overlooked to the most dangerous pattern in modern geriatric medicine, a pattern affecting an estimated 1 in 4 Americans over 65 right now, and almost no one is talking about it. Stay with me through number 1, because number 1 is not a single drug. It is something far more sinister, and it may already be happening to someone you love. Before we go further, do not stop any medication without speaking to your doctor. That is not what this is. This is about informed advocacy. You have every right to understand what is going into your body and what it is doing to your brain. Knowledge is not dangerous. Silence is. Tell me in the comments right now, are you over 60? What medications are you currently taking? I read every comment. Your experience could help someone watching this today. Number 9, diphenhydramine. Benadryl, Unisom, anything labeled PM or nighttime. The Trojan horse. Raise your hand if you have a bottle of Benadryl on your nightstand right now. It says sleep aid right on the label. It costs $3. It seems like nothing. Here is what that little pill is actually doing inside your brain. Diphenhydramine belongs to a class called anticholinergics, and you're going to hear that word repeatedly today, so remember it. These drugs block acetylcholine, the brain's primary memory neurotransmitter. When you're young, you have reserves. When you're over 60, you're already running on a lower baseline. Block even more of it nightly, and the damage compounds invisibly over months and years. A landmark study in the Journal of the American Geriatric Society found regular diphenhydramine use in older adults was associated with measurable shrinkage in memory-related brain regions, visible on neuroimaging. The trap? It hides in everything labeled PM, nighttime, or sleep formula. People don't realize they've been taking an antihistamine every single night for years. What to do? For allergies, loratadine or cetirizine, Claritin or Zyrtec, they don't cross the blood-brain barrier the same way. For sleep, safer options are coming at the end of this video. Number 8, proton pump inhibitors, omeprazole, Nexium, Prilose, the long con. How many of you have been taking an acid reflux pill every single morning for years without anyone ever suggesting you try to stop? PPIs were designed for 8 to 12 weeks of use. They are now taken indefinitely by tens of millions of people. And the problem goes deeper than stomach acid. Your stomach acid extracts and absorbs vitamin B12 from food. B12 is not optional for brain health. Deficiency is clinically linked to memory loss, depression, and nerve damage, symptoms that so closely mimic early Alzheimer's that experienced physicians sometimes confuse the two. A 2016 study in JAMA Neurology of over 73,000 adults found long-term PPI users had a 44% higher risk of dementia. Separate research has also linked PPIs to accelerated amyloid beta plaque accumulation, the hallmark protein buildup of Alzheimer's disease. What to do? Talk to your doctor about tapering using famotidine as a bridge. If you stay on PPIs long-term for a genuine medical reason, test your B12 and magnesium regularly, non-negotiable. If this is landing, type 8 in the comments. It tells me this is reaching the people who need it. Number 7, bladder control medications. Oxybutynin, ditropan, the invisible damage. This one genuinely frustrates me, not because of the condition, overactive bladder is real and disruptive, but because of what nobody tells patients when they hand them this prescription. Oxybutynin is one of the strongest anticholinergic drugs still in widespread use. It doesn't just act on your bladder. It crosses the blood-brain barrier easily and directly attacks the same acetylcholine system responsible for memory and learning. Studies show long-term use causes measurable reduction in hippocampal volume, not brain fog, not fuzzy thinking, actual, physical, structural brain tissue loss. A 2019 study in the British Medical Journal found seniors using oxybutynin for more than 1 year had a 49% higher risk of dementia diagnosis, nearly 1 in 2. The heartbreaking part, the early symptoms, forgetting appointments, losing words mid-sentence, get chalked up to just getting older. The drug is never questioned. What to do? Newer bladder medications, like mirabegron, work through a completely different mechanism with dramatically less cognitive risk. Ask your urologist specifically about this switch. Number 6, benzodiazepines. Xanax, Valium, Ativan, Klonopin. The calm that kills slowly. I want to say something clearly before this one. Benzodiazepines have helped millions of people through genuine crises. I am not dismissing that. I am asking you to hear the science. Benzos amplify GABA, your brain's natural calm-down signal. They work. The problem is what happens when that mechanism stays switched on for months or years. A 2022 study tracking over 8,000 seniors found those who used benzodiazepines for more than 3 months had a 51% increased risk of Alzheimer's disease. The risk was highest for long-acting forms like diazepam, which accumulate in brain tissue over time. When GABA is chronically over-amplified, your brain begins to reduce its own activity in response. Neuroplasticity, the brain's ability to form new connections, learn, and adapt, deteriorates. Memory encoding slows. The brain, being calmed, begins losing its capacity for dynamic response. And the trap is brutal. Withdrawal is often worse than the original symptoms. Rebound anxiety and insomnia make the drug feel necessary as it causes the damage. Critical warning: never stop benzodiazepines abruptly. This can be medically dangerous. Work with your physician on a slow, supervised taper. Alternatives: buspirone for anxiety, CBTI for insomnia, low-dose magnesium glycinate as bridges. Number 5, statins. Simvastatin, atorvastatin, or Lipitor, the good drug with a blind spot. I have to be careful here because statins genuinely save lives. Cardiovascular disease is the #1 killer over 60, and for many patients, statins are appropriate and necessary. I am not telling you to stop yours. But here is what your cardiologist may not have told you. Your brain is composed of nearly 60% fat. Cholesterol is not optional. It forms the myelin sheath, the insulating layer around your nerve fibers. It is critical for synapse formation. Without adequate cholesterol, neurons struggle to communicate. The FDA updated statin labeling in 2012 to include warnings about memory loss and confusion, a rare acknowledgement issued after reviewing thousands of adverse event reports. A 2023 analysis in Frontiers in Aging Neuroscience found seniors over 70 on high-dose statins for more than 3 years showed measurable increases in mild cognitive impairment. The critical nuance: not all statins carry equal risk. Lipophilic statins, simvastatin, atorvastatin, cross the blood-brain barrier more readily. Hydrophilic statins, pravastatin, rosuvastatin, show significantly less cognitive impact in comparative studies. What to do? If you're experiencing brain fog on a statin, ask about switching to a hydrophilic version. Also, have your CoQ10 levels checked. Statins deplete this compound, critical for cellular energy in the brain. Number 4. Amitriptyline, Elavil. The wolf in sheep's clothing. This one surprises people every time because amitriptyline isn't prescribed for depression anymore. It's prescribed for nerve pain, migraines, fibromyalgia, and insomnia. It sounds benign. It is not. Amitriptyline is one of the most potently anticholinergic medications still in widespread use. Its affinity for acetylcholine receptor sites is higher than many drugs specifically designed as bladder medications or allergy treatments. A landmark 2015 study in JAMA Internal Medicine followed over 3,400 adults aged 65 and older for 10 years. High cumulative anticholinergic exposure, with amitriptyline among the top contributors, was associated with a 54% greater risk of dementia. And the damage wasn't dramatic, no sudden warning sign, just a slow, invisible erosion, word-finding difficulties, problems with sequencing, a creeping inability to hold complex thoughts attributed to normal aging for years before anyone thought to look at the medication. What to do? For nerve pain, duloxetine or gabapentin carry far less anticholinergic burden. For sleep, low-dose stoxapen has a far more favorable receptor profile. For mood, sertraline and other modern SSRIs are significantly safer for aging brains. Number 3. Antipsychotics. Quetiapine or Seroquel, risperidone. The darkest chapter. I need you to pay close attention because what I'm about to tell you happens every single day in nursing homes and memory care facilities across this country, and most families never find out. Antipsychotic medications were developed for serious psychiatric conditions, schizophrenia, bipolar with psychosis. They are powerful, brain-altering drugs. Today, they are routinely prescribed off-label to elderly patients who are simply confused, restless, or agitated, not because they have psychosis, because they are inconvenient for short-staffed caregiving environments. I'll say that again. There are seniors in long-term care facilities right now being chemically sedated, not for their benefit, but for the operational convenience of the facility. The FDA issued a black box warning about this practice over a decade ago, citing increased mortality in elderly patients with dementia-related behaviors. The prescriptions continue. A 2022 study in the Lancet Healthy Longevity, tracking more than 25,000 older adults, found seniors given antipsychotics for behavioral symptoms were 71% more likely to experience worsening cognitive decline within 12 months, even with no prior dementia diagnosis. If you have a loved one in a facility, ask why this medication was prescribed. Ask what the plan is to stop it. Ask what non-pharmaceutical behavioral interventions were tried first. You are entitled to these answers. Do not accept vague responses. Number 2, paroxetine, Paxil. Here's one that almost never gets the attention it deserves. Paroxetine, sold as Paxil, is classified as an SSRI, the same family as Prozac, Zolofto, and Lexapro, and when people hear SSRI, they think safer, modern, better tolerated. That is true for almost every SSRI. Paroxetine is the exception. Unlike every other drug in its class, Paxil has significant anticholinergic activity. While sertraline and escitalopram leave acetylcholine largely undisturbed, paroxetine interferes with it in a way that much more closely resembles the old tricyclic antidepressants. A 2021 review in Frontiers in Psychiatry found elderly patients on paroxetine showed measurable declines in short-term memory and verbal recall within the first year, declines not observed in patients on other SSRIs at comparable doses. The American Geriatric Society has placed paroxetine on their official Beers criteria, a list of medications considered potentially inappropriate for older adults, specifically because of this cognitive risk. The fix is straightforward. If you're over 60 and on Paxil, ask your physician whether switching to sertraline, Zoloft, or escitalopram, Lexapro, would provide equivalent benefit without the anticholinergic load. Most patients transition successfully with careful tapering. Number 1. Anticholinergic polypharmacy. The real epidemic. Every medication on this list, taken alone, might cause only subtle effects. A little more brain fog, slightly worse recall, easy to dismiss, easy to blame on age. But here is what happens in the real world. The average American over 65 takes 4 or more prescription medications daily. Many take 6, 8, 10, often prescribed by multiple physicians with no full visibility into each other's decisions. When several of those carry anticholinergic properties, they don't simply add to each other. Research suggests they can multiply the effect. A 2022 analysis in Age and Aging tracked over 280,000 older adults. Those with the highest anticholinergic burden, measured using the validated anticholinergic cognitive burden scale, had a 120% increased risk of developing dementia over 10 years. Double the risk. From pills. Pills that most of them had never once been warned about. Let me make this real. Meet Dorothy. She's 72. She takes Benadryl PM every night for sleep, oxybutynin for her bladder, amitriptyline for foot pain, and an OTC heartburn pill every morning. 3 of those 4 are anticholinergic. Each one, according to her separate prescribers, is safe and appropriate. Together, her anticholinergic burden score may be in a range clinically associated with significant dementia risk, and not one doctor, not one pharmacist has done the math on her behalf. This is not a hypothetical. This is Dorothy. This is Patricia. This is your mother, your neighbor, your spouse, right now. The medical term is anticholinergic polypharmacy. It may be the single most underreported driver of dementia-like symptoms in the elderly population today. Here is what I need you to hear. Drug-induced cognitive decline is often reversible. I have seen it personally. When medication burden is identified and systematically reduced under proper medical supervision, many patients experience a remarkable recovery. Memory returns, personality reemerges, the fog lifts. Patricia is proof. Your brain is not passive. It is adaptive. It is resilient, and it is capable of healing when given the conditions to do so. Your 5-step action plan. Step 1. Write down everything you take, every prescription, every OTC product, every supplement, every occasional sleep aid. Nothing gets left off the list. Step 2. Look up your ACB score. Search Anticholinergic Cognitive Burden Scale, free and publicly available. Score every item on your list. Step 3. Schedule a medication review. Use that exact phrase with your physician. I'd like to schedule a medication review to assess my anticholinergic burden. A good doctor will not be offended. They'll be glad you asked. Step 4. Ask about deprescribing, the intentional, supervised process of tapering off medications that carry unacceptable risk or are no longer necessary. It is a legitimate and growing field of geriatric medicine. Step 5. If dismissed, get a second opinion. You are not being difficult, you are being responsible. A geriatric pharmacist, yes, that specialization exists, can perform a comprehensive medication review. Before you close this video, think about one person you love who is over 60 and on multiple medications. Think about whether anyone has ever had this conversation with them. Send them this video. You might be the reason their fog lifts. You might be the reason someone gets their mother back. Tell me in the comments, which of these medications are you or someone you love currently taking? Have you noticed memory changes and never connected them to a prescription? I read every comment, and sometimes the most important thing is simply knowing that what is happening to your mind is not inevitable. I'm Dr. Deborah William. Your brain is worth protecting, and now you have exactly what you need to start. Stay sharp. I'll see you in the next one.